Do children snore?
Absolutely.
So they can actually have sleep apnea as well, just like adults.
Just like adults. We're always asking about sleep, and I'm always asking about noisy sleep or restless sleep. And my goodness, do my parents come in with like a video of their child sleeping? They're like, hey, Dr. Filstrup, I took this video of my child last night, and look at how they're snoring or how they're extending their neck up to like get more air in, or how they might stop breathing at certain points, like sleep apnea, and then all of a sudden they wake up with a big kind of like a snort or a large noise to like open up their airway. And so it starts to affect the whole craniofacial complex in a way that you could start to, now we could see some asymmetries, right? Then one side kind of takes over growth over the other side. And if uncorrected, that could continue into adulthood.
Right.
You may not know this, but by age 4 years old, 60% of all of our growth of our craniofacial complex is complete.
Wow.
So age, that's young. And so we're uniquely positioned as pediatric dentists or pediatricians, like growth is already happening. Right. And by age 12, 90% of that growth is complete.
Hello, welcome. My name is Dr. David Fiorillo. I'm a general and cosmetic dentist in the Boston area.
And I'm Dr. Sarah Filstrup, a pediatric dentist in the Boston area.
And my wife.
Yes. Welcome.
Welcome to the Smile Experience, a podcast that's geared towards the person that's interested in the health and the science, the art, and maybe some stories and the whole body experience that comes with your smile.
Yeah, we like to say we smile on the outside, but we smile on the inside
right,
too.
Yeah, we're here to help you smile, but also make you feel better on the inside too.
Absolutely.
Today we're going to be covering a pretty cool topic. I'm excited for it because I'm going to learn something, and Sarah's going to be covering the airway and in children.
Yeah, pediatric airway, and we have done an airway episode, but this one maybe focuses more on young children and growing, developing children. Not only their, physical growth and development, but their, cognitive growth and development, and even socially, in terms of how airway can affect us.
I'm kind of excited. We talked a lot about how the different factors with people with, how the air gets into their nose.
Yeah, I think it's the same in that we're kind of just in general talking about how do we get the air to our lungs, right? And there's two ways that we can, right? We can breathe through our nose, we can breathe through our mouth. And as we've talked about and are firm believers, we know that breathing through the nose is significantly more healthy than breathing through our mouth.
The air goes into your nose, it goes into the turbinates, it goes into your sinuses, it gets warmed, it gets filtered, it gets, oxygen's getting pulled out, it's getting, I
think that's the number one, like the air coming through our nose is specifically designed for our respiratory system, right? So it's gonna clean the air, it's gonna filter the air, it's gonna condition the air. Is it the right humidity? Is it the right temperature? All in, ways of getting the air ready for our lungs to receive it, so we're not hurting our lungs. The second thing we do know by breathing air through our nose is that we create nitric oxide. And what nitric oxide does is it's a vasodilator. Okay. So it dilates our vessels.
I was going to ask what it does.
Right, yeah. So it dilates our vessels so that we're able to uptake, the oxygen in our blood and deliver it to the rest of our body, as well as clear our carbon dioxide. And, as being a pediatric dentist, one of our main focuses is growth and development. And this impacts airway and breathing, impacts our growth and development immensely. Another important thing that by breathing through our nose is we stimulate our parasympathetic nervous system. This is what, why you breathe deeply in and out of your nose when you're in yoga. Okay. It calms us. It allows us to recover. It decreases our fight or flight response,
just
right?
Breathing slowly just makes you feel better.
It's kind of amazing, for you, right? And it's better for you. And I guess if we're talking about why it's so important to breathe through the nose, maybe from a counterpoint, and this is our really kind of what we focus on so much, is if you're breathing through your mouth, think about what that's doing. Like think about our saliva,
Sure.
which
Yeah.
we probably don't give enough credit to.
Right.
Like our saliva is there to neutralize our acids, wet our mouths so we can talk and chew and function. It's so protective, and if you're breathing in and out of your mouth, now your mouth is dry.
Yeah, you're drying everything out.
Yeah. So it's like one is so great for you, and the other, you can just think of so many detrimental things that can happen in terms of our teeth and mouth and health. So with adults, we were talking about it last time. People, they can kind of tell a lot of times that they have an airway issue. They may say, "Hey, listen, my partner told me that I snore," or "I'm tired all the time, I'm fatigued." How is that different? I mean, how do you tell with kids that they have an airway problem? Yeah, this is a great thing, because parents will ask me these questions all the time, because as you know, these are some of the buzzwords that they might hear when they're just out and about with their parents. But I'm always kind of break it down into what are some of the things that we could see? And just like you, I'm always watching my children as they walk in the door. Yeah. Are they my children that are breathing with their mouths agape and open and kind of elongating their face to get the air in? Are my kids that are really, and I feel like you see it more on children, have almost a dark circling under their eyes, like a little Venus pooling under their eyes, like they're not getting enough sleep.
Do children snore?
Absolutely.
We don't have children.
Yeah.
And I'm the youngest of 7, so I had no reference. But do kids really snore?
They do, and that's one of the second things. First of what do I see, and I think we'll talk a little bit more about growth and development and what we see in the mouth. But this is what I see just as my family's walking through the door. But two, we're always asking about sleep, and I'm always asking about noisy sleep or restless sleep. And my goodness, do my parents come in with a video of their child sleeping, because they're checking in on their kids all the time for various reasons. Yeah. And so I think they're like, "Hey, Dr. Filstrup, I took this video of my child last night, and look at how they're snoring, or how they're extending their neck up to get more air in, or how they might stop breathing at certain points, like sleep apnea, and then all of a sudden they wake up with a big kind of a snort or a large noise to open up their airway." And so they bring in to show me specifically, I'm not just going to talk about it, I want to show you what I'm seeing.
So they can actually have sleep apnea as well, just like adults?
Just like adults.
Okay.
And maybe even more, which really makes it so very important, and maybe we could do an intervention before they're at the adult age, is that in terms of the growth and development of our whole head and our craniofacial complex, it's amazing. I mean, you may not know this, but by age 4 years old, 60% of all of our growth of our craniofacial complex is complete.
Wow.
So age, that's young.
Yeah,
and so we're uniquely positioned as pediatric dentists or pediatricians, growth is already happening. Right. And by age 12, 90% of that growth is complete.
So by, would you say 6 or did you say 4?
By 4,
so by
60%.
4, my gigantic fat head was
already there.
60% of it was already.
Yeah, the shirts, when parents are struggling sometimes to get shirts over the kids' heads.
Okay, so
my own nephew, my sister would have to cut the shirt.
Oh, wow.
It would be, because our heads are already almost 60% developed.
So if they have issues, intervening early is important, is what you're saying.
And what we may see, if you kind of think about it, and this is your wheelhouse because it has to do a lot with musculature and form and function, is that if you're always walking around with your mouth open, right? Your mouth is open, your lower jaw's dangling, your cheeks from the outsides are pushing in.
Yeah.
Children, their bones are so spongy. I mean, all of our bones are spongy, but even more spongy, that it can start to constrict their upper jaw. So parents might notice that, hey, my child's always kind of biting to the side, and it looks, or I tell them to do a smile, and I'm like, what are you doing? Why is your jaw doing that? And it's because they're already getting some constriction of the upper jaw. The child's just finding a way, how does my lower jaw fit against my upper jaw?
That's good. Wow.
So they're very malleable. So by changing the position of where our musculature is and where we're positioning our lower jaw, it starts to affect the whole craniofacial complex in a way that you could start to, now we could see some asymmetries, right? Then one side kind of takes over growth over the other side. And if uncorrected, that could continue into adulthood.
Right. So if you see that with the child, you see these things going on, how do you help that?
That's a really great question, because it's such a continuum. Like, what if some of my children, or a lot of my children, we might just practice, like, let's say parents will come to me all the time and the children are very drooly. And young kids do drool. That's what they do.
I don't think I ever drooled.
You probably did.
I don't think
you probably had a bib catching all the drool.
I don't. Okay.
But sometimes that drooling can linger a little bit, or they might just be holding their mouths open.
Yeah.
If you think about it, our lower jaw is so unique. They're trying to figure their bodies out. So we might practice like lip closed breathing, where maybe during book time or quiet times at home, we practice, just closing our lips and breathing in and out of our nose. They may be, if they have noses that are a little bit kind of plugged noses, maybe it's just allergies. Some parents, maybe it's just they do a little saline in the nose, or maybe they realize, hey, allergies, well, this year in New England, they're pretty intense, that maybe they might have a medication to help them with their allergies, to help them breathe through their nose. But as we talked about, sometimes it is structural.
Yeah.
Sometimes these kids will open wide and the first thing that bubbles out are their tonsils. And you're like, oh my goodness, it must be hard to even eat and swallow. And so that's when we might get our colleagues, our ear, nose, and throat colleagues involved, or our pediatrician colleagues involved, to really say, hey, this change in this child's airways affecting not only their great breathing, not only growth and development, it's also then, as we've touched upon, which is so important, their sleep.
Yeah.
And without great sleep, that affects so many things.
I've heard of friends complain about their child having their tongue tied. Is that a factor with airway, and what does that mean?
Yeah, that could be. That's a whole different kind of, but it does have to do with the lips and tongues and the mouth.
And just to clarify, that's when the little attachment that's at the bottom of the tongue is short, right? And so they can't put their tongue up.
Yeah, and that's usually addressed really early on, because if someone has a distinct tongue tie, it usually affects their latching ability when it comes to feeding. And that's usually diagnosed, or at the University of Michigan, we would go and we might do a little relieve the tongue tie in the hospital, so that the parent could then breastfeeding or bottle feeding could happen.
What about pacifiers? Could the pacifier cause a problem for airway? Is it, or thumb sucking? Is that something that could actually cause a problem for children? Or when do we all know we did it. So when does it become a problem? Yeah,
it can, but not always. Pacifiers are a great thing. You get sent home from the hospital with a pacifier. We know, our colleagues, the pediatricians, by having an infant have a pacifier at nighttime reduces the risk of SIDS, or sudden infant death syndrome. So it is something that pediatricians are already introducing, a pacifier. Now, that being said, that same pacifier that you, leave the hospital with shouldn't be the same pacifier that you use as we grow, right? Your palate's growing and expanding. You wouldn't want to have this little infant-sized pacifier that when you, kind of your.
I didn't know they came in different sizes.
Yeah, they come in different sizes. Medium, yeah, and I think it's a buzz right now. There's different ways that they're starting to look at what size might you have. But I think just in general, it should never be the same size that you've gone home with.
Well, I was a pretty big baby. So I was 10 and a half pounds, 24. So I probably had the age 2 probably pacifier, right?
Yeah.
My sisters were so bummed.
Yeah.
It was such they wanted a cute little baby, and I was blob.
You were just
so I probably should have had
a
bigger toddler size pacifier. I didn't know they came in different sizes.
Yeah. Yeah. And so, but with a pacifier, there's so many great things, and it really doesn't have to make any changes in the airway. Actually, it kind of forces them to breathe through their nose, which is a great thing, right? We already talked about all the great reasons why we want to breathe through our nose for our health. some kids just kind of hold it in there. I love it. My parents know this. We talk about it all the time. When used at appropriate times for bedtime, to help them to go to sleep in the whole with the pediatricians and our recommendations. But two, I love it for the fact if they're using it for self-soothing, right? Like, I don't know, they take a big tumble, they fall a lot. Children do. We know this. That if they go to get their pacifier to kind of calm them down, think of what that's doing from a behavioral standpoint. They're already learning to be a self-soother, which we need for the rest of our lifetime. Right. So I love it from that perspective. But you're right, in terms of...
But at like 16, you need to move it on, right?
Yeah. We do say, as an Academy of Pediatric Dentistry, we say by age 3. Okay. And that's kind of a great number for parents. Okay. That being said, some of my parents are like, hey, they might have a new baby that's on the way, and they're like, we're going to do this now. And you can do it in so many different ways. Usually we make big fanfare. The pacifier fairy could come. Parents will bring me things too, that they'll package up the pacifiers and then I'll send to the children. So we make it like it's a big step. The big kids don't use their pacifiers. But you're right. If some children, it depends really if it's going to start affecting their teeth, right? You see those children where maybe the top teeth are kicked out a little bit, right? Where the pacifier is sitting, it's kind of pushing those front teeth out, which does lend those teeth to get bumped or bonked along the way, to have more trauma to those teeth. But that being said, once the pacifier we're done with our pacifier, amazing, we've celebrated. Our musculature around our lips, right, it's circumferential, it'll start to bring those teeth back to the position where they started. Cool. But you're right, parents might notice that first, the movement of the teeth, or why does this tooth, and oftentimes children don't put the pacifier right in the center. It could be to the side. So you could have like a side kick.
Oh, that's cool.
So parents do. They notice this.
So one of the things that we talked about in the adult sleep apnea and in the airway part was some of the things that we can do to help. And we could, help make people appliances. We could help direct them to their physician, surgeries or different aspects. For children, do you make them appliances if they have airway problems or apneas, or is it usually always surgical? What do you do to help when that patient comes in with, you notice stuff going on? What is it that their dentist can do?
Yeah, that's a great thing, because I think early intervention, it can be something as very simple as kind of getting us to breathe through our nose, can make a huge difference in allowing us to have symmetric growth and development with our jaws. If you're to the point where maybe the teeth are kind of kicked out, pacifiers that we talked about, then maybe we're urging that maybe that child, just the way in which they suckle the pacifier, it's just really putting a lot of force on the teeth. So maybe that encourages us, like, you know what, we knew this was coming. It's time for that passy to go to the fairy. So that might be one thing that we change. But if we're already seeing, kind of some asymmetries, right, that we talked about, maybe because we're having a difference in our musculatures, or because our lower jaw's down, that means our side muscles are coming in and constrict our upper jaw. Sometimes if you just catch it early and we're getting to nose breathing, you'll see that kind of correct with growth and development. But if we're beyond that, sometimes we do have to kind of widen out that upper jaw.
Isn't that when kids have
like an expander
early on orthodontics to intervene in there and maybe widen out their palate? I think I never had one, but we have a lot of people talk about having to turn the little key that moves that widens your palates, and sometimes in adults, even one of the surgical aspects is, and it's a little obviously tougher on adults because their skull is the sutures that allow things to be moved in orthodontics are closed or fused. So it's more of a challenge. We can do it with implants, so they can actually expand. We have something to grab onto and expand the palate. But with kids, you can move them all day long, right?
Yeah, which is great. It's usually an early intervention, like you said, because that suture that goes down the roof of your mouth remains open or patent till around age 10 or 11. So usually you want to, when we're directing, maybe if we're going to modify or widen out, you want to do it when the suture is still open, meaning there's still cartilage there. So by putting a little bit of forces orthodontically.
Yeah.
We can move those shelves apart, and then the bone fills in. So we're just helping the form and function, except for this time, instead of like brain growth and growth and development, we're assisting it a little bit, which I think we're almost always doing. I always say the best orthodontist is Mother Nature, is our own bodies. But if there's some little interval that we can intervene and assist with that and get us back on track, that's the opportune time to do it.
So for the parents that are, they see some of these symptoms, they see some issues, getting them to see the dentist, getting them to see the orthodontist, getting them to see a dentist that can do ortho, and help assist, I would imagine, is a pretty important thing early on.
Yeah. And that's where, it really does, I think pediatric dentists champion this, because we see the children, every 6 months time, if it's their own individual interval. So we can really watch growth and development happen. Cool. So it's a great and an honor to be in that position, to be able to help patients and their families.
I'm seeing the patients farther down the road, so it's pretty cool that you can get in there and do that kind of treatment early on to really kind of help that out.
Yeah, it really sets the foundation for health, right? And then maybe they're not even talking about those adult, things that we spoke of, because we've kind of set up their bodies for success.
Yeah, some good information. So, get your, if you're having those issues with your child, or you're concerned, your dentist is a good line of defense there to kind of like help solve those problems.
Yeah.
That's impressive. And don't just tape their mouth shut. It's not, apparently that's not something we should do.
It does kind of bring up a good point, because you did ask about, frenums and tongue ties. Like, we start seeing our child patients at age 1.
I was going to say, when do you see kids?
We say age 1, if not when the first tooth arrives, or if I have parents coming in with very young children, no teeth, but yes, we're looking at those muscle attachments. We're looking at the mobility of the tongue, the lips, and kind of, again, trying to make sure, hey, is growth and development, are we where we thought we'd be? Are we setting the stage up for success for these children?
Sure. I think you gave not just the smile experience of the children, but I think the parents could be something to smile about, knowing the fact that, like, there's that much they can learn from it, and that much they can treat their child with as well too.
Thanks for listening to this episode of the Smile Experience, Pediatric Airway. I truly believe it's the foundation for our health. And if you're out there as a parent or a caregiver and maybe something resonated, or you're like, gosh, well, what are my next steps? What if I'm worried about snoring or disrupted sleeping, or my front teeth are protruding a little bit on my child? Like, talk to your pediatrician, or talk to your pediatric dentist, schedule an appointment, and we're always here to help in any way that we can. I hope you found that informational and learned a little something.
And remember, if you have any questions or any comments, feel free to leave a comment and let us know. Maybe you have some issue or something you want to learn more about from this episode, or another topic that you want to hear about.
Yeah.
Feel free to let us know in the comment section below. Thanks for listening to the Smile Experience, and we'll see you on the next one.
Thank you.